Second point, the overlap is very interesting because these struts are 150 microns. So if you overlap of a long region, you have 150 plus 150 plus 300. So altogether 600 micron. And we have done a lot of animal work. It took more time to have re-energization at the side of the overlap. So if you look very carefully at the end of these scaffold, there is a tiny radiopaque markers of about 37 micron. I cannot see from here because it's a transmission, but in the
next,
yeah. Certainly in the lab, if you zoom and focus, you will see these markers. And then there is a technique to reduce the amount of marker. The markers are not really at the very end of the stand. They are in the last loop. And what we do is that we pull and try to avoid
So let's move ahead. Dr. Serraz made a very interesting comment on the markers. I will show this in details ahead. Breno, please move to the next one.
Ribamar,
another view of the coroner.
Ribamar, can you hear me, please? Yes.
Okay, Dr. Fausto, perfect.
Okay. We, as I understood what Patrick said and what you have done, we are changing the technique right now. We always was advised to pre-dilate it with low pressure to avoid dissection at the pre-dilatation. Now we are a little bit oversized in the pre-dilation. We were like in a vessel that was 2.4 distal. We use a 3O balloon at 12 atmospheres. Could you make comments about that? What is the
Yes.
experience and to get a dissection, like a spiral dissection at the pre-dilatation? Maybe Patrick can also mention something about it.
Actually, Dr. Fausto, it's a bit more aggressive than we do routinely with metal stents, but as I mentioned, by IVUS, this was a vessel close to 3.0 at distal, not 2.5. 2.5 was by Angel. And the recommendation is to do a 1-to-1 balloon vessel ratio, predilation. We don't need to oversize too much. It's 1-to-1. It's just to really prepare the lesion. Dissections will happen because that's the mechanism of balloon. You all know better than me this, but as Dr. Serra said, we will prepare the lesion, the plaque, and then put the scaffold to seal the dissections and to keep the vessel open. That's the idea behind it.
The vessel size is chosen by IVUS or by Angel?
In this case, and in our site, we are choosing by IVUS. Okay, Breno, next, please. Next. We did OCT as part of the overlapping protocol. This is the run. It's very fast. It's still with the first generation. We just received the C7. I have the still image later to show you. As you can see, we don't see as in metal stents. Next, Breno. We don't see those metallic struts with the shadows. We see these boxes, as Dr. Serraz has described this in details in the past. And an interesting point, we can see the light going through the box, and we can see perfectly what happens and what is behind the scaffold that was just implanted. And one important detail is that branch, the AV branch, wasn't touched by the scaffold. We didn't protect it, we didn't do anything. It's still there, and fortunately didn't close. We can see the IVUS and the OCT images just to illustrate. Next, please, Breno. For the LAD, we did again the DMAX as part of the protocol, but we sized it by IVUS as well. By IVUS, it was smaller than the RCA. Actually, it was close to 2.7. Next, Breno. Next, please. Here you can see it's an eccentric lesion. It's a bit more than 60-70%. Go on, Breno. We pre-dilated with a 3.012 at this time at 8 atmospheres. We were a bit more conservative. Next, Breno. And we implanted a scaffold at 3.018 at 12 atmospheres. Next. We post-dilate with a non-compliant balloon 3.015 at 14 atmospheres again. Next. And this was the result. You will see there is a mild plaque distal to the stent, but the lesion was perfectly covered, and the stent conformed well to the vessel. I don't know if you want to comment this part of the intervention.
This is a very important aspect, the conformability, and Dr. Siraius published how conformability is an independent predictor of restenosis. And it's shown that this scaffold presents with more conformability than the metallic stent.
The other aspect that we discussed in Rotterdam a few weeks ago for the focus session of Euro PCR, and Patrick perhaps can jump in, but there was a kind of consensus that with the scaffold, we have to be perhaps more aggressive with pre-dilatation, but not so much with post-dilatation. Of course, there are a little bit concern of fracture. This is a plastic material, it's not metallic material. I think that we're going to be a little bit more tolerant if there is a little bit residual stenosis after scaffold, and I would like to see what Patrick has to say about that.
Yeah, I think that there is three key words: sizing, good pre-dilatation, and no post-dilatation. So the sizing is very important, and you could say that angiography is underestimating the size. The OCT is pretty correct, is really the best technique, and the IVUS is slightly oversizing. So it's a question of which technique you feel confident. I mean, if you feel confident with angiography, you do with angiography. The big advantage of angiography is that you have co-registration, as a matter of fact. At the moment you push the device, you see the contours of the vessel by injecting the contrast. With OCT and IVUS, you have a cross-section image, but you don't have a co-registration. And even if you have co-registration with the angio and the IVUS, you still have to have the co-registration of the device and the contour of the vessel. That's the first point. The second point is that we are moving into a more generous dilatation, doing like in the good old days, you know, inflating until suddenly the waist is disappearing. That could be 8, 9 atmosphere, but generally it's not higher than then. And if it's higher than then you need another technique to open that vessel. And then the dilatation of the device itself, I used to do 3 atmosphere, 2-3 atmosphere per 5 seconds. So a dilatation would take 45 seconds and go to a 16, 18, and that's it. I don't retouch with post-dilatation, because when you do post-dilatation with generally a short balloon than the device, you have some kind of shear of the plastic material, and in phantom it doesn't look very good. And most of the time I do the OCT after, and I'm surprised to see that all the struts are well opposed. So it's really a question of sizing and good preparation.
I think this is very important, because what you're hearing is that we really are changing our technique. You've got to be really sensitive about the size range of the device. So the pre-analysis of the vessel size, lesion length is less forgiving. You have to be more precise. You have to be more aggressive with preparation, pre-dilatation, and with the right sizing of the device. Basically, you have to try to avoid post-dilatation as much as you can. So it's a little bit the reverse of what we have evolved into with metal stenting techniques, and I think everybody should be aware that there will be a little bit of relearning, you know, how to best deploy these scaffolds.
One question.
Totally agree. We have to perhaps retrain our brains here when we move to this new technology. I would like to see if Jose did OCT in this case.
No, yeah, we did OCT and IVUS, but I think for the sake of time, I will skip to the still image. Breno, next, please. Next. Okay, next. I'm not going to show the, no, next, please. Next. Okay, one more. Just to show that the stent was fully opposed and the expansion was pretty much reasonable all along the stent. By IVUS and by OCT, you didn't see any fracture, you didn't see any significantly underexpanded region or malopposed, especially at the edges. Next, please, Breno. This is not part of the study protocol, but in our institution, we are trying to do 1 week later MSCT, so we can follow these patients non-invasively. It's part of the protocol to do this in the follow-up later, but we decided to do also in some cases baseline to compare. And this patient 1 week later was started with MSCT, just to stress what Dr. Serraz previously mentioned. We can, next, Breno, please, the arrows. Yeah, we can easily see the markers at the edges, at the end of the stents. This is, just to remind, this is the RCA, the proximal and the distal markers. Next, Breno. And at the overlapping, that, as Dr. Serraz said, should not be very long segment. As you can see by MSCT, it's very small overlapping segment, and you can see the two markers barely, we can see the separation barely between them. It was very short overlapping segment. Next, please. And the LAD as well. Próxima, Breno. Next, please. The proximal and distal markers, and we can see by MSCT that distal to the stent, there was that plaque that I showed at angio that was moderate. There is some calcification distal to the stent by angio, by MSCT, sorry. Next, please, Breno. Next. This patient came to us 2 weeks ago as part of the follow-up, 9 months follow-up, and he complained of atypical chest pain. He said that he had some chest pain, but it was not something similar to what he did, to what he had prior to the intervention. But anyway, we decided to evaluate this patient better. Next, please, Breno. We decided to do what we consider still the gold standard, the scintigraphy, to evaluate the presence of ischemia, but also we decided to do a CT scan as well. Next, Breno. As you can see by the scintigraphy, no sign of ischemia at all in any of the segments that were previously diseased, the inferior wall and the anterior wall. It's a perfectly normal scintigraphy. Next, Breno, please. And this is the 9-month MSCT of this patient. The markers and the full patent stent. Maybe we can say that it's a small late loss, a small loss at the mid to distal part, but very insignificant. And the vessel is fully patent at the RCA. Next, Breno. And the LAD also very patent. And the plaque distal remains the same or even less calcified, if we can say that. I don't know if you want to comment on this, Dr. Fausto.
No, it's just a wonderful case, and it just showed the 9-month angio follow-up. I totally agree with this patient is just fine.
Yeah, I think that's what the audience should realize, the beauty of that. I mean, we have just completed the 60 months follow-up for initial patient, all with multi-slide CT scan and non-invasive FFR. So it's very pleasant to see 5 years later the location of the device and have the FFR just before and just distal to the device. You have, of course, the FFR of the whole vessel, but it's very elegant way, and the patient